So at this stage, Dr. Rachel Rubin will speak to us on libido, arousal, and how I use testosterone in clinical practice. Thank you.
All right, so here's the QR code again. It might be the same QR code. I'm trying this QR code thing out for the first time, so we'll see if it works. But this should be all the slides, the updated slides. They asked me to do a lot in 45 minutes, and so as you could see from the last one how fast I talk, we'll see how I can do in this one. And I think it is of big interest to so many of you is just having the comfort level of how to write the prescription. As a urologist, I write testosterone prescriptions a lot, right? I take that for granted, how comfortable I am talking about testosterone and how much I see testosterone magically change my patients' lives, all of my patients who take testosterone, how I have so much clinical experience. And so it matters, and it matters for you if you have no clinical experience or if you've never written a testosterone. For my GYN friends, many of you have never written a testosterone prescription for. Some of you don't have DEA licenses because it is like you're prescribing opioids, which makes no sense at all, right? This is a hormone your body makes naturally. The fact that it is DEA regulated is kind of wild. So we're going to talk about testosterone today. I will do my best. I'm sure there will be more questions. And as I said, 10% of you will throw tomatoes at me, which I can handle these days. So come at me with whatever you got. This was a big day. This was, was this July? This was July. We were invited to the FDA to talk about hormone therapy in general. And actually, it was we probably should talk about the politics of even getting this room together. Who didn't show up? Who was invited? Who did show up? Who should have shown up? But sort of, it's a really delicious story that I won't tell on stage today. But we actually all met, and we really spent a lot of time trying to figure out what is our ask. And the majority of people actually didn't want to ask for anything other than label changes on vaginal estrogen, because we never in a million years thought we could get more. And we have been burned so many times. I actually went to the FDA with a group of people a couple years before. There was another citizens petition a couple years before that. We'd been multiple times getting told no, no, no. And so there was a lot of sort of discussion, which some of us who are in this room could tell you about, but we were like, wait a minute, they didn't invite an orthopedic surgeon to talk about vaginal estrogen. They didn't invite the neuroscientist to talk about that. They want to hear about all of it. And I encourage you to watch this because it was pretty deliciously exciting, but Dr. Kasperson gave her we each got 5 minutes. And my 5 minutes were good, but her 5 minutes were really good. And so she did 5 minutes all about testosterone, some of which women had never heard before, about what she sees about testosterone in her practice. And many of us do testosterone therapy, but we anointed her as sort of our sponsor in that moment. And so I encourage you all to watch it. And it was at those discussions, right, that led to a big day in November where they announced the warning labels. They surprised everybody, even the people in that. We didn't know what they were going to do with this information, but with all the public comment and all the excitement, and they actually removed the label on all hormone therapy products. And so we didn't know even that we could ask for those things. And so history is kind of an interesting thing. But what was even interesting, and many of you may not know this, but actually the men were like, wait a minute, you guys can make changes, we want that too. And it was sort of fascinating because we got so much press, okay? I'm not one to brag, but I got CNN and Fox News to agree on something. We got the Washington Post and the New York, and the Wall Street Journal to agree on something. Women's health was actually all in the news that day in a good way. There was actually very little anger because actually was all in all a good day, and we could argue about the minutia, but this was all in all a good day for women's health. And so the men said, we want that. We want the attention because they actually have issues too. Men's health is not without controversy, without politics. It's just different. And so male testosterone actually has a lot of really, really interesting parallels to women's hormone therapy. A lot of interesting parallels. And so the men were like, well, look how much press the women got. We're gonna get just as much press because we're men. And they didn't do anything to promote themselves or to advertise themselves, and they did not get as much press. I digress. But my friends, and these are all my friends, got into a room to talk about testosterone therapy for men. And they did talk about women's testosterone. There's one line where they talked about women's testosterone therapy, which my friend Dr. Mokera said, but they actually had some really interesting asks, which actually will really help women's hormonal health dramatically. They asked to deregulate testosterone so that it is no longer required for all of you to have a DEA license, which is insane, right? They asked for improvement in sort of the indication for male testosterone, like hypogonadism. It should be age-related, like it should just be hypogonadism. And so they did this. And so like the women's health one in July, they had a period of public comment. Well, the men expected all of the public should comment on male testosterone. They must care about this, but guess what? The men do not care. Because the men who want testosterone are on a lot of it, and the men who aren't on testosterone don't realize that they might need it, and they never heard of it. And so they actually had about almost 2,000 comments, but they were all from women. 90% of the public comments were all of you saying, "Where's ours?" Okay, they were all about, we want a product for women, and that's so interesting. Oh, I just think that's so interesting. I feel weird up here, so I'm gonna come back down. So menopause, I may have to stop saying this because there's been a lot of good PR, but really has a terrible PR campaign. This idea that it's hot flashes and night sweats and they only last for a little bit of time, this is of course the audience that knows that that is not true, and it was never true. It is so many symptoms, it's every cell in your body, it affects your eyeballs, your ears, your vagina, your GI tract, it affects all of it. And we just forgot to tell the neurologists and the dermatologists and the rheumatologists and all those people, and so it's everything. But the thing is, we've known this about men for quite a long time. It takes a lot for us to castrate men, just so you know. As urologists, there is one indication where we do castrate men, and it's for metastatic prostate cancer. Women, you can have like the theoretical abnormal cell in your body and we'll castrate you quicker than you can say castrate. But for men, you have to like have prostate cancer in your bones for us to want to use that as a target for our therapies. In fact, actually just this week, the New England Journal of Medicine published a giant double-blind randomized placebo-controlled trial in using high-dose estrogen patches in men with metastatic prostate cancer. So our patch shortage is about to get worse because men with metastatic prostate cancer can use 8 patches a week, 8.1 patches a week, a month, a week, and 4.1 patches, and like they studied that and they had no bad things happen to them. In fact, they got a little gynecomastia, okay? But like no hot flashes, no fractures, like their bones were better, like with metastatic prostate cancer. It's fascinating, right? So good and bad. What helps men will help women, but it'll happen a lot quicker for men. So anyway, when we do castrate men, they have all these symptoms, and it's devastating to, like anyone who takes care of metastatic prostate cancer knows how devastating erectile dysfunction, metabolic syndrome, cardiovascular disease, osteoporosis, hot flash, like literally the only men on earth who deeply connect and like feel for menopausal women are my metastatic prostate cancer patients. Like they're the only ones who get it. Because every woman is this. Right? Like if you live long enough, like this will be you, and like you shouldn't have to suffer with all of these things. So this idea of testosterone is just for libido. It makes no logical sense. Why would it work for men's bones and their brains and their libidos and their, like, and all this, like, their like mood and like their just a general well sense of being, but it wouldn't for women? It doesn't make that much sense. Nor is the data even like suggest that that's true. This is, Dr. Casperson showed this, but this is the New England Journal of Medicine showing that it helps. This is in fully castrate women not on estrogen therapy, and it improves libido, arousal, and orgasm. what would happen if you added estrogen to this? The answer is what I see in my clinic every single day is like good stuff, people, a lot of good stuff. So we know that the androgen receptor makes all these proteins that does all these things that my nerdy, non-basic science brain doesn't quite understand, but that it is important for the urethra, for the bladder, for the brain, for the muscles, for the heart, which is just a muscle, right? Like testosterone matters for all of those things. Ooh, Dr. Kasperson, you could write a book, Testosterone Matters. There's your next book title. She's like a lot of books in, so I just give her ideas because she's way more prolific than I'll ever be. So, by the way, like it's so fun to have friends in this space. This job is so much more fun with friends. I could never do what these people do, and yet I get to be a part of it and watch them, and it's like so fun. So have friends in this space, it's really fun. Do we have no, like, is it really just HSDD? And the people who are against testosterone, by the way, when you listen to them, and they try to convince you that testosterone doesn't work for women, you'll hear them say, well, the only data that we have is if you're really bothered by your low libido, and there is some data about orgasm, but that doesn't really matter. Like, they literally will tell you that it works for libido and orgasm as though that is a bad thing, or that it doesn't matter. I will tell you, when you take someone who loses their orgasm, I had this woman, I swear to God, I had this patient. She said when she was in her mid-30s, it's like amitriptyline day, she said she was put on amitriptyline for her migraines, and she lost her 3 magical orgasms. This is a true story. She said, I just assumed it was because of the amitriptyline, that it was a medication side effect, but it really helped with my migraines. So yeah, I lost my 3 orgasms. And she didn't know that she could act. So she came to see me. She was in her like late 50s, early 60s, and ultimately with shared decision making, all this stuff, we decided she wanted to be on estrogen and testosterone and progesterone and vaginal hormones. And she was doing fine on estrogen and progesterone and vaginal hormones, and she decided to start testosterone. I usually stack it, like Dr. Hirsch says, and I do it one thing at a time kind of thing. And I always tell patients it takes about 4 to 6 months for your testosterone to kick in. But everyone has a moment where they're like, oh, it's working. And it's not immediate. I can tell you my story, it's pretty funny. But this woman, so she's 5 months into testosterone, and she comes back to the clinic, and she says, they're back. Her 3 orgasms came back. And it wasn't the amitriptyline at all. It was her drop in her testosterone. Anyway, so we know the vestibule is full of testosterone receptors. We went over this data. So when you play and mess with hormones, there are consequences. That doesn't mean I'm anti any of these medications. It means that all medicines have side effects. And when you tell patients that, right? I have many patients who need birth control pills because it's life-saving for any number of reasons that you know birth control pills are wonderful for. That doesn't negate the fact that there are side effects. And so sexual side effects are just as important as blood clot side effects for many of our patients. We do not get to decide which side effects are important to our patients. And so again, there's lots of androgen receptors in this tissue. So when I use, the only time I compound is again at that vulvar vestibule, and I don't do it in everybody, but when their symptoms and their exam tell me that they need it, look what happens at 6 weeks. This is just 6 weeks of a little estrogen and a little bit of testosterone, right? Like, holy crap, right? You don't have to be, you have eyeballs. You can see that this makes a huge difference in this person's life, right? You have eyeballs. They're really smart now after my last lecture. This was one of my favorite abstracts because read the conclusion. Okay, so this was a randomized, double-blind, placebo-controlled trial of testosterone for the treatment of postmenopausal women with aromatase inhibitor-induced arthralgias. How cool that someone did this study, okay? In conclusion, the dose of testosterone in this study does not improve arthralgias. That's the conclusion. But when you read the results, patients receiving testosterone reported improvements in strength, lack of energy, urinary frequency, and stress incontinence, all statistically significant. The subset of patients receiving subcutaneous testosterone also experienced improvements in hot flashes and mood swings. But that's your conclusion? How about the pelvic floor? The pelvic floor is full of testosterone receptors. This is why women get worse prolapse and leakage and pelvic pain as they get older, right? Because they're losing, like your muscles everywhere start to atrophy. Your pelvic floor is no different, and there are tons of testosterone receptors. This was a very cool, large database study that looked at people on testosterone therapy and said females with testosterone therapy had lower risk of major adverse cardiac events, DVT, PE, and malignant breast neoplasm. Just libido? Really? Okay. How about studies since the 1940s? This is a slide from my dear friend. Actually, the way you found me was at Harvard does a testosterone course for men every year. Abe Morgan-Tyler, who is my hero and truly pioneered the field for testosterone in men, and all I did was watched him, and I said, I'm going to do that. We're going to do that, but for women. And that's everything you're seeing right now is we just took the playbook that was done to prove that testosterone doesn't cause prostate cancer, that testosterone is safe with prostate cancer, the saturation model. All we're doing right now is saying we saw him do it for men. Now we're going to roll up our sleeves and try to do this for women. And so that course, he was my idol. And he asked me to come teach a couple years ago at his testosterone course for men to do the female content. And there's this researcher, Abdul Traish, brilliant basic science researcher, and he posts these, since 1941, we have had tons of data for testosterone in women that goes long beyond libido. So when you find yourself in that exam room saying, oh, it's not prime time, there's no data for it, this is just social media influencers, really? Really? I don't know about that. Okay. How about on mood? This is a lovely study that was done out of our friends in England who actually started the menopause revolution. And they looked at 500 women who were on just a little topical testosterone every day. And they looked at all of these different things and saw mood improved more than cognition, but 47% of women had an improvement in their mood, and almost 40% had an improvement in their cognition. And the 3 symptoms most likely to improve were the loss of interest in most things, crying spells, and the loss of interest in sex. Memory problems were the least likely to improve, only 34%. Only 34%. I love how people, it's wild, like the idea, oh, just libido. Oh, these influencers, darn these influencers that are board certified doctors. Headache, we're having neurologists start to look at testosterone for headaches. That's kind of fascinating. People looking at it in breast cancer patients. I know you guys talked about that yesterday, and to watch the oncologists start to wake up because we're diagnosing breast cancer earlier and earlier, and yet we're not helping them live their best lives. And so again, what are we afraid of? Well, why can't we actually study it and look at the data that we already have and say, well, actually, we don't actually not that afraid. And if we want to keep women on their endocrine therapy, then give them the tools to support them. I love that Dr. Men says this, right? Like, before my cancer, you gave me all these things to help with the side effects of chemotherapy. Why wouldn't you give me things to help with the side effects of these endocrine therapies? It just, logic, people, we use logic. Now we have logic and data? Oh my. But just a bunch of influencers, right? Again, all of these things were improved with testosterone therapy, arousal, orgasm, libido. My patient didn't come to see me for her 3 orgasms that were missing, although it would have been great if she had. I would have tried to help her. But what a beautiful consequence of her hormone therapy. What a beautiful, beautiful consequence. So how about the eyeball? This is my new favorite topic. There are androgen receptors. How many people have dry eye in menopause? So many, so many. If someone's raising their hand, so many. And so there's actually studies that have been done and are currently being done on using testosterone drops in the eyeball. And that's amazing, okay? Just libido, though. So testosterone comes from the adrenal glands. It comes from the ovaries, just like it comes from the adrenal glands and the testicles in our male patients. We always had more testosterone in our body than estrogen. In fact, we do a disservice because we put estrogen in picograms per milliliter and testosterone in nanograms per deciliter, so it looks like we have much more estrogen in our body, but the units are all off. So when you put everything in picograms per milliliter, or if you're in other countries, probably other units that I have to put into Google to convert to the units I understand, we have lots more androgens in our body than we do estrogen. Whether it's testosterone, androstenedione, DHEA, it's by many folds higher, right? And so this idea, again, these old graphs that we were given was like, okay, men have testosterone, women have estrogen, men have a little estrogen and a little, it just doesn't really work. We also have this age-related, right? So you've got estrogen, you have no estrogen, then you have this about 100, you live in this reproductive land between 50 and like 300 probably, and then it goes to 0 again. Testosterone, right, goes up in puberty, and then it just like starts to drop in your 30s. Then it's actually not due to menopause. This is the curve that we all would study right before an exam because none of us could remember what luteal phase was. I know you did. I know you still look at this, I do, right? Like this is the curve we are taught when we are examined, when we're being like told to take a test on the menstrual cycle. But like, there's no testosterone on this curve because we haven't or we shouldn't. Haven't or shouldn't, right? Like there's no testosterone on this curve, and yet we tell patients all the time, your testosterone peaks at ovulation so that you want to make a baby. Like, does it? Where's that data? And was it based on 20 people back in the 1920s? Like, we have to start questioning this stuff. So again, we see this age-related decline, and again, the people who talk about this will say, well, it's not about menopause, so we shouldn't talk about it. Yeah, it's not about menopause, it's about like perimenopause, which is before menopause, and we should talk about perimenopause. So testosterone starts to drop. Now, there are guidelines that have to do with testosterone, and they often just say look at the total testosterone. Now, that is also true in men's health. We look at total testosterone. But many of us who do this work, and when I'm extrapolating on what I know for men, and I believe that homologs are very interesting, so just to give you an idea, it is important also to think about sex hormone binding globulin, which attaches to testosterone. So if you look at people, men or women who've never taken a birth control pills, their sex hormone binding globulin is about 25. Now, anyone who's taken a birth control pill, their sex hormone binding globulin, you'll see these wild numbers. It goes really, really, really high. Well, let's see if that matters. And it may not, like this is where, again, we're just asking questions. I'm not saying this is guideline driven, but look at this. I think of like women have like 10 times less testosterone than men. So I think about normal like male testosterone, think 300 to 1,000, right? So that if we have 10 times less, think 30 to 100. Again, those are ish numbers. Let's say ish numbers, because numbers don't actually matter for diagnosing low libido. And there's no number where you say, oh, you're normal. So if someone has a total testosterone of 40, think 400 in a man, okay, that's like pretty good, that's fine. SHB of 25, free testosterone here is 0.8, which is pretty good, right? Like 2%, 0.6 to 0.8, that seems pretty good. But say her testosterone's 40, but her SHBG is 125, so her testosterone didn't change. But then you add the effects of a birth control pill that she took 10 years ago, now her free testosterone goes to 0.2. Well, that's a big difference, right? So we're asking questions of like, just because the number is normal, could the proteins that bind to the free testosterone be affecting symptoms? Maybe. And as we think of this idea of like an empty gas tank, what if we added some, like what are we afraid of? We give 10 times the amount of testosterone to people who are transitioning, like trans men, and like they do okay. So like what are we afraid of? Are we harming people by giving 10 times less the dose? So what are the guidelines? Well, we've got guidelines for hypoactive sexual desire disorder. We've got amazing guidelines in GSM, genitourinary syndrome of menopause, that have the word androgen all over them because the genitals and urinary tract have androgens in them. So now we have guidelines, so low libido, genitourinary syndrome of menopause, and while I don't have guidelines, we have lots of clinical experience and data for hormonally mediated vestibulodynia. This, again, your papers in that QR code, read the global consensus. It's very conservative and interesting and actually reads just like male testosterone guidelines. It shows that it's really safe. It's not that serious. My TLDR, my too long didn't read on testosterone, it feels serious and actually isn't at all, right? Actually, last year when I was here, I put my own testosterone on for everybody and everyone thought I was crazy. it's later in the day. I've already put my testosterone on, and I'm wearing tights, so I didn't do it today. But this idea of it's not that serious. No major harmful things do we see, even when you do 10 times the dose in our trans patients.